Jeanette Boyd. I'm a family physician who works in the wonderful community of Nelson, BC. I am very, very fortunate to work there. I'm always eternally grateful every day that I work with the fantastic group that I do. In terms of our medical community, it's fairly similar to Whitehorse, at least in terms of a medical obstetrics perspective. We have 5 family physicians who deliver babies. We have 5 midwives who deliver babies. We have 2 obstetrician gynecologists who provide consultative services. They don't do any primary maternity care. And then we have 1 GP surgeon. So, we have a similar number of care providers, maybe just slightly different balances. So keep that in context as I kind of go through. I was very fortunate to do the last 2 months of my family medicine residency up here in Whitehorse, actually. I worked with Dr. Stephanie Buchanan and a little bit of time up in Dawson City. And while we were here, my family took on a very interesting quest to build a raft and raft down the Yukon River. That's our raft. And that's, I didn't get to go because I was on call. But that's them not making the turn just before Lake LaBarge and kind of drifting off into, just before you get to Lake LaBarge. Now, fortunately, they did lodge on a sandbar and were able to wade to safety. However, what I mean by this is that although we did the reading, we did all the perspectives, we hadn't really planned appropriately. So I just want you to keep this little journey in the back of your mind while we go through. It was a 6-year-old and a 2-year-old too, to give perspective. We're trying to push that in. Anyway, so the current environment of rural maternity care is one that is constantly in flux, and it is one that is very vulnerable, as we all know. Somebody earlier referred to the joint position paper on rural maternity care that has all of these wonderful groups associated with it. So Canadian Association of Midwives, SOGC, College of Family Physicians and Surgeons, Society of Rural Physicians of Canada, and the Canadian Association of Perinatal and Women's Health Nurses. Out of that paper is 14 different recommendations. The first 2 are there's high quality of maternity care as close to home as possible, which is something we all have a quest for. And then the provision of rural maternity care must be collaborative, woman and family centered, culturally sensitive, and respectful. And that's certainly a theme that I've heard coming all the way across. We all know how vulnerable communities are. We know how vulnerable maternity care are in smaller communities, and the tremendous challenges that people living remote and rural have to trying to access maternity care and what it means for their communities when they have to leave their communities to access that care. We all deal with different stereotypes. So the physician, when you're talking with the midwifery community or people who really want a midwife birth and people who really want a physician birth, there's sort of these different stereotypes around it. But what ultimately is really important, both from the physician and midwife perspective, is that you want a healthy family at the end of it, a healthy baby, a healthy mom, a satisfied customer, a satisfied client. But just, you want good outcomes, and we all have that at heart. And another really important thing that my colleague Dr. Mula says often is that who are we to think that we know better what's best for that particular child? So we also have to keep that in mind, that aspect of choice. Like I can't say that I have the best interests of that baby at heart compared to the mother or the father of that baby. So it's just another perspective to keep in mind. So the principles of care as we go through, professional autonomy, partnership with the women who are involved in our care, continuity of care provider, all of this will be familiar to the physicians in the room. Informed choice, we all have the principles of care of informed choice. Evidence-based practice, high quality of care, doing quality improvement initiatives, etc. Collaborative care is also within our scope of practice. But interestingly, this is the list from the Canadian Association of Midwives. Although it resonates with all of us as physicians, it's almost identical to what we deal with as physicians. So I've highlighted the similarities between our principles of care. They're almost identical, other than the choice of birthplace, perhaps. And interestingly, the midwifery program at UBC is under the Department of Family Medicine. So we all have the same sort of intents and purposes, the same approach to care, and just slightly different. So there are certainly variations in care. Choice of birthplace is one that's quite highlighted by the midwifery community. I am a family physician who does do home births in very select situations and very select populations with incredible support from my midwifery colleagues. And it is certainly allowed by the College of Physicians and Surgeons of BC. It is not beyond my scope. Scope of care is absolutely different. They spoke about midwifery focusing on normal birth, which is true. Family physicians have a more broader perspective of training, but again, we do believe in that birth is a totally normal and natural process, and we are there to support it through and identify those situations where it perhaps verges off the normal guidelines. So low risk is one of those terms that's thrown around, and I do like the idea of talking about it as normal birth versus low risk, because things can change. Difference is sort of absolutely the longitudinal aspects that family physicians are trained to, and I think that gives us a unique perspective when looking at birth. Me as a family physician in a rural small town, I love when I take care of the entire family all the way through to newborn babies, and their grandmother and the great-grandmother is in my practice, and they're all at the birth in the room with me. It is just such a tremendous and wonderful gift that I have as a rural physician. Probably one of the biggest differences between family physician care and midwifery care is the amount of time that we're able to spend with those families. Midwives have a wonderful luxury of being able to provide detailed consultation, which we as family physicians, we will ultimately always find time in our practice if we do have those patients who are higher needs. But certainly from a midwifery model, it's built to facilitate that, and it's much easier. You're not dealing with the waiting room full of people if you are dealing with a more complex situation. So collaborative considerations, and I do want to speak to this very briefly. Bringing in a new model of care isn't about necessarily trying to fix something that's broken, but it probably is about building something different and something better. It's not to say that the current model of care is not high quality. It absolutely is. But as we evolve, we do realize that sometimes we can do things a little bit differently that maybe will enhance the care, we can think about it from the ministry aspects of the triple aim in terms of the costs that we worry about, and then patient and provider satisfaction and those sorts of things. But ultimately what it comes down to is, are we doing the best that we can? Are we all working to the top of our scope? And truly collaborative practice where we can learn from each other and work together is the way that all of us can learn to work at the top of our scope. All of these people, and I do have another slide that includes lactation consultants, but not EMS, I'm sorry, but it's so important. I'll include it. All of us do have our roles change when one of these people come into a community. Maybe you didn't have an obstetrician practicing, or maybe you didn't have a GP surgeon in your community, and all of a sudden you do. And everybody kind of has to find their new roles and their new places. And it just takes time and that openness. So that is certainly something that we need to consider. I'm going to put EMS in this slide later. So ultimately, though, both family physicians as well as midwifery view the pregnant person and their family in the center of care. And ultimately what the models of care that we're moving towards, both in BC and from a national perspective in thoughts like the patient's medical home, talk about building this sort of circle of care around the pregnant person and their family, and bringing in these resources as they're needed according to the patient's or the client's or the woman's needs. And this circle can certainly be expanded to include people like social workers and physiotherapists and EMS if you need an urgent transfer and those sorts of things. So there are many ways that we can work together. Certainly one of the more familiar models when you do have midwifery in your community is working in parallel. So midwives have a separate practice and they consult the specialists, and that's about it. There's other aspects where, for example, in Trail, which is a community very close to where I live in Nelson, the midwife will consult with the family physicians in terms of getting things like like an augmentation order for oxytocin or something along those lines, or a medication order, which will be changing over the next little while. Family physicians can function as second attendants at home births, which is a really lovely way to get comfortable with doing a home birth, I've discovered. Other call models in CREST and the family physicians provide call relief for the family, for the midwife, so she can take some time out of community, or oftentimes they'll need to go somewhere where they can get a little bit more volume, or just to take a vacation, and the family physicians will cover their practice while they do that. And vice versa. I don't know if it made the news up here, but very recently in Cranbrook, another rural community in BC, they had 11 deliveries in 24 hours in a very small hospital, and the midwives came in to help the physicians with their deliveries. So it was, it's all about that. And another example is a formal collaboration where it actually is a shared group, shared population, and that's one of the collaboratives I work with. And there's different compensation models. I won't really go into it. There's fee-for-service, which most physicians are familiar with. There's course of care that midwifery care is, where you're paid per first trimester, second trimester, birth, postpartum. There's different call stipends and consultant stipends, and then there's also pooled billings models. There's lots of different ways that you can go about working collaboratively or working in a consultative way that really acknowledges the unique aspects and skills that each of these members of these groups, disparate groups, can bring to the field. Perinatal Services BC in November of 2015 did a very interesting perspective of looking at collaborative models of maternity care in BC. It was a qualitative analysis, and they looked at what are some of the attributes of successful collaborative maternity models. They looked at physician-midwife models as well as physician-physician models. Ultimately, the aspects that they found were unique, were common threads throughout, were the collaborative champions. There was always one or two, and if it was a physician midwife collaborative, there needed to be a physician and a midwife who were championing it. But there was always somebody who was up at the fore of bringing that forward. There is a tremendous amount of organizational aptitude and administrative work that's involved when you have any sort of collaboration, and that was a huge barrier, but also a facilitator once you had the right people there. Funding is always something you have to consider. People need to make a living wage, and you need to be recognized for your work. All aspects of collaboration had some degree of either a crisis or sustainability needs, or there was a collaborative workshop, an opportunity where people can come together and talk about what were the unique needs within the community, and how can you address those unique needs. And if it was, there was a strong desire for midwifery care, or that you had a physician couple who was leaving your community, and all of a sudden you halved your number of care providers, and all of a sudden you're in a crisis. And so ultimately there were always areas when these collaboratives were born where there's those opportunities to share and really look at co-generating opportunities for meaningful work together. There was always an amount of time that was spent coming together to talk about continuity of care, philosophy of care, those sorts of things. Sometimes there were shared spaces and shared resources, and ultimately there was always conversations around cohesion, equity, and uniformity. And that doesn't, that doesn't necessarily, it's a little bit misleading in the way it's phrased. Cohesion is probably a better word, in that everybody has the intention of working towards supporting that family to have the birth that they want to have. And if they can't have the birth that they want to have, supporting them through that decision-making process to help them feel comfortable with ultimately how things ended up. So our lovely little raft ended up stuck on a sandbar at the mouth of Lake Labarge, and I apologize to anybody for the navigational hazard that did cause. But what ultimately it did show is that you need the right tools. You need ultimately something that is going to have a direction. You need a plan to move forward with that. So a canoe was a much better tool for navigating through that journey. So there are certainly essential ingredients to any sort of collaborative care or any introduction of a new model of care to any community. Emma Butt was a midwifery student who worked with us at Appletree Maternity, and she had lots of, she did an analysis of this and also looked at a literature search. And the essential ingredients to a collaborative model of care or a new model of care are mutual trust and respect, a common philosophy of care, commitment and desire to collaborate, clear and effective communication. You need those clear communications. You need charting. If it's electronic medical records or whatever, you need clear handovers. All of the things that were brought up as concerns, those are essential. You need a model that's responsive to the unique needs of the community. So the model that works in Trail, an hour down the road for me, it does not work in Nelson. And what works for us is not going to work for you in Whitehorse, but what can work is sort of following these aspects and learning from each other and finding a very community responsive approach. You need the support of the community. If their midwifery isn't desired in the community, it's, you know, the midwives aren't going to get the care and, and the women they deserve. And ultimately, midwifery, it is strongly desired, and that is certainly clear when I was doing some research before I came up here. Midwifery, it's desired by the community. You need a supportive institutional culture. The midwives, the groups, they need to get privileges. They need nurses who are willing to work with them. A really good example is when I started working with midwives, the nurses weren't quite sure what to do with me. Do they treat me like a midwife or do they treat me like a physician? I do still work in a family physician call group, and I have a slightly different role when I'm working as a midwife versus when I'm working as a physician, so it does take some adaptation. But the hospital I work in is tremendously supportive of that and very resilient around that. And then alternative payment plans and billing structures is essential. You need to find some way, again, to help people make a living wage. I had a few different reflections just listening to different comments and concerns that people were bringing up around introduction of midwifery, of regulated and funded midwifery care in the Yukon. There were concerns around resiliency and sustainability in the physician and the nurse population. So I will admit that in Nelson, when we came up with our maternity collaborative, midwifery care had been present in Nelson since 1998. So it was a somewhat different situation than that, different than here, although there is midwifery care here. And the concerns that it might dilute the population or dilute the experience and the deliveries that the family physician population will do. But I want to speak to the concept of resiliency in that I moved towards a collaborative model of care because I was worried about my colleagues burning out. Because I was worried about, if we had one or two of our colleagues be sick, all of a sudden the call schedule falls on a very small number of people. You need to have, in any rural community, when there's a small number of providers and a small volume, you need to build in redundancy in order for that model to be sustainable, in order for you to do the other things that you need to do and spend time with your family, and I am not at all concerned. Women's choice is important, the mutual respect, and you're standing up, so I'll finish. The mutual respect, and then ultimately the opportunity to learn from each other. I have learned so much from my midwifery colleagues, and they have learned so much from me and the aspect of us working together. And at the workshop, I can speak a little bit more about our model of care that we have in Appletree. Thank you.